Hello, good morning, everyone. Thank you for joining us today. My name is Suminan from Yonsei University Gangnam Severance Hospital. I'm one of the chairs of this session, bariatric surgical session. This session is co-chaired by Professor Moon-won from Asan Medical Center. This session title is Advanced Bariatric Surgical Concepts for Bariatric and Metabolic Surgery. I'd like to explain the session progression first. After each speaker's video stream, we have Q&A time with the speaker. If you have any questions about the presentations, please click chat the right side of the video screen and write down your question. If your question are picked, you can earn a Congress point as well. I'd like to introduce the first speaker, Jiyeon Park, Professor Jiyeon Park from Kyungpook National University. She's working at the Chilgok Hospital and actively participating the KSMBS as a chair of academic committee. She'll give us a lecture today titled Update on Bariatric and Metabolic Surgery. Professor Jiyeon Park, please give us a lecture, please.
Good morning, ladies and gentlemen. I'm Jiyeon Park from Kyungpook National University, and today I would like to deliver a brief updates of bariatric and metabolic surgery. Over the last 10 years, the prevalence of obesity in all obesity classes has gradually increased in Korea. One thing to note is that the class 3 obesity, which is BMI over 35, has almost tripled over the last 10 years, which reached over 0.8% in 2018. This means 1 out of 125 Koreans is morbidly obese now. If you have a closer look at the data according to the different age groups, you can see that the prevalence of obesity is rapidly increasing, particularly in the younger generation of age less than 40. Strikingly, the increasing speed of class 3 obesity is even faster in this population. The prevalence reached 1.6% in 2018, which is 3 times or more than those of the older generation. This indirectly indicates that the number of patients eligible for bariatric and metabolic surgery is rapidly growing in recent years in Korea. As most of you already know, the Korean National Health Insurance Plan began to cover bariatric and metabolic surgery since 2019. The patients with BMI over 35 or those with the BMI over 30 and have obesity-related comorbidities are now qualified for the insurance coverage when they have surgery. Those with lower BMI of over 27.5, along with the poorly controlled diabetes, are also qualified for the metabolic surgery with the partial insurance coverage. Korean nationwide registry data have shown that there has been a gradual increase in the number of procedures, particularly the lap band up to 2013, when the year when the lap band related issue occurred in Korea. The number of procedures dropped thereafter, and band procedures seem to almost discarded during this period. Since 2019, after insurance coverage, the procedure number tripled and reached around 1,500 cases in a year. However, this increasing tendency did not seem to continue on in the following years. The statistics in 2020 show that the sleeve gastrectomy accounted for 75% of total procedures, followed by 12% of gastric bypass. An interesting survey was conducted back at the end of 2019 in order to understand the level of awareness of bariatric surgery among primary physicians. Interviewees were 60 family medicine or internal medicine doctors, and interestingly, almost half of the physicians working at the private clinic were not well aware of the insurance coverage of bariatric surgery, and this was more pronounced among senior physicians. After informing them about the insurance coverage, they were asked again if they would recommend bariatric surgery for eligible patients. Still, 11 physicians answered no, and one of the main reasons was concerns about the safety of the bariatric surgery. They also were not sure about the true efficacy of surgery and about to whom or which surgeons they should refer their patients. So this survey showed the issues that we surgeons need to solve in the upcoming years in order to enhance the uptake of bariatric surgery in Korean society. The worldwide trend has shown that the overall procedure number has been quite steady over the last 2 or 3 years, which was around 700,000 cases in a year. As expected, slave gastrectomy is the most popular procedure around the world since 2016, which takes up of 55%, followed by 30% of gastric bypass. Now let's have a look at the studies on the long-term outcomes of bariatric surgery. One of the monumental clinical trials from Italy lately released 10-year long-term outcome in this year, 2021. Dr. Mingrone and his colleagues compared the efficacy of metabolic surgery in patients with obesity and advanced type 2 diabetes. They enrolled 60 patients, that was 20 patients in each group of medical therapy, biliopancreatic diversion, and gastric bypass. To remind you, the patients had diabetes duration of 5 to 7 years, HbA1c level of more than 8.5% at baseline, and half of the patients were already taking insulin at the beginning of the study. At 10 years of follow-up, they found that 50% of BPD group and 25% in the Roux-en-Y gastric bypass group still maintained diabetes remission status and did not require any anti-diabetic medications at all, although some of the patients experienced diabetes relapse. The median diabetes-free survival was 5 years in gastric bypass and 9 years in BPD group. Of course, surgery group showed greater weight loss of about 30% initially, and it was pretty well maintained for 10 years. Diabetes-related micro and macrovascular complications occurred 14 times less in the surgery group than in the medical treatment group during these 10 years. These results show that the metabolic surgery is much more effective than the medical therapy, even in the very long-term control of diabetes. And this study also suggests that the type 2 diabetes might be a potentially curable disease. Of course, there were some trade-offs for the excellent glycemic control in the gastric bypass. 15 years of follow-up after gastric bypass has shown that the significant number of patients suffered from micronutrient deficiencies, as shown in this table. Iron deficiency anemia was the most frequent problem, which occurred in 52% of the patients. And one of the reasons for these deficiencies might be a spontaneous interruption of the supplementation therapy. And they found that 35% of the patients in this study did not comply with the daily multivitamin supplementation. Therefore, we should be aware of this problem and need a strategy to persuade patients to follow the long-term supplementation and regular surveillance plan after gastric bypass. After its adoption as a standalone procedure in early 2000, we are now able to see a long-term results of the slave gastrectomy of more than 10 years. This very well-known clinical trial conducted in Finland, SLEEP-PASS trial, has released 7-year follow-up results lately. At 7 years, the mean excess weight loss was 47% in slave gastrectomy group and 55% in gastric bypass group. And gastric bypass achieved 8.7% higher excess weight loss than slave gastrectomy. The difference still was not clinically relevant based on the predefined margin of 9%, but it seems that there is a clear tendency toward bigger difference over time favoring gastric bypass. So gastric bypass appears to be better in terms of sustained weight loss than slave gastrectomy. Weight regain after sleeve gastrectomy has long been discussed issue. In the meta-analysis, which included 9 long-term studies of more than 7 years, the incidence of the regain was nearly 30%, when regain is defined as a excess weight loss decreased down to 50% after successful weight loss. It seems that a considerable number of patients would experience weight regain after sleeve gastrectomy, although the exact definition of the weight regain is not settled yet. Another major concern about the sleeve gastrectomy is the novel GERD. The incidence may differ depending on the diagnostic methods or follow-up duration, but one of the recent studies reported that the incidence of symptomatic GERD reached 50% after sleeve gastrectomy at 10 years, and these patients became dependent on the chronic PPI use due to the symptoms. Therefore, we should carefully discuss these potential problems with the patients before performing sleeve gastrectomy. The incidence of Barrett's esophagus after sleeve gastrectomy is reported at 4.6% from studies with a patient follow-up of more than 2 years. This is higher incidence compared to the general population. And in this year, IFSO recommended regular endoscopic screening at 1 year and then every 2 or 3 years after sleeve gastrectomy, although the cost benefit is not clear yet. Then how many patients are going to have revisional surgery after sleeve gastrectomy? This meta-analysis, including 32 previous studies with more than 6,000 sleeve gastrectomy patients, show that the revision rate after sleeve gastrectomy gradually increased over time after surgery and reached 22% after 10 years. The most frequent reason for the revision was weight regain after sleeve gastrectomy, which occurred in 11%. Followed by the intractable GERD. So this result suggests that in Korea, we should also be prepared for the weight regain after sleeve gastrectomy in 5 to 10 years, since sleeve gastrectomy is the most popular procedure in Korea right now. Since studies have shown that the long-term results of sleeve gastrectomy are not always very promising, there has been a growing interest in sleeve plus procedures shown in this figure. Actually, this status, the single anastomosis duodenal ileal bypass procedure, is not very new. Spanish group started to adopt this status procedure back in 2007, which is a modified version of original BPDDS. They changed Roux-en-Y into loop anastomosis to make surgery technically simpler and made longer common channel of more than 200 centimeters to avoid long-term nutritional problems. This group serially reported an excellent excess weight loss, which was almost 100% at 3 years, and also excellent diabetes control up to 5 years, as shown here. Also in Japan, Dr. Kusama began to use sleeve DJB procedure in diabetic patients because Roux-en-Y gastric bypass was not reimbursed by insurance due to the gastric cancer risk in Japan. They reported that sleeve DJB achieved an excellent weight loss of 30% at 5 years and also about 60% of diabetes remission, and they suggested that the sleeve DJB is very effective in long-term weight loss and diabetes control. Now, it seems clear that there is a growing attention to these sleeve plus procedures. Although they are technically challenging and evidence for the long-term outcome is still not sufficient, they are very attractive because they show better weight loss and metabolic outcomes than sleeve gastrectomy alone, and pylorus preservation reduces the risk of marginal ulcer or dumping, unlike gastric bypass. Furthermore, we don't need to worry about the gastric cancer in the excluded stomach. So I think probably in Korea, where gastric cancer is highly prevalent, this sleeve plus procedures is expected to increase in the near future. The next thing I would like to talk about is weight regain after surgery. Causes for weight regain after primary bariatric surgery can be various, and these include non-compliance to the dietary education, psychosocial problems, anatomic failures, and so on. Therapeutic options for weight regain also vary according to the different causes, from behavior therapy to surgical revisions. Among them, patients with anatomic failure and some with the metabolic problems can be potential candidates for the revisional surgery. After failed banding, conversion to sleeve or gastric bypass has been widely used. So far, studies reported similar weight loss between two procedures, and meta-analysis also showed that there was no difference in weight loss at 12 months. However, long-term results are required to provide a clear answer to this question. After sleeve gastrectomy, conversion to gastric bypass has been the most frequently used option for weight regain. In the meanwhile, some other surgeons supported re-sleeve gastrectomy or conversion to sadis as shown in this figure. It seems that re-sleeve gastrectomy could achieve effective weight loss, particularly in non-super obese patients with localized pouch dilatation. However, patients with diffuse tube dilatation, as shown in this picture, were highly likely to show a poor response again after re-sleeve gastrectomy. What about the conversion to the gastric bypass? Previous studies have shown somewhat disappointing weight loss results, although the number of patients in this study was very small, which is not enough to draw a concrete conclusion. BMI loss after revisional bypass was unexpectedly low, which was only 2.5 points at 2 years. It seems that the revisional surgery was much less effective in weight loss than primary bypass surgery. So conversion to gastric bypass can be a feasible option for intractable GERD after sleeve gastrectomy, but its additional weight loss effect is questionable so far. Conversion to sadis showed excellent additional excess weight loss of 72% after weight regain as shown here. But the data is still very limited with small sample size, and further studies from a larger number of patients are required in the future. So we can summarize the surgical option after failed sleeve gastrectomy like this based upon the previous study results. If there is focal pharyngeal dilatation, the re-sleeve might work, but in other cases, particularly in those with refractory GERD, gastric bypass appears to be the best option. If there is no evidence of GERD before revision, then sadis or duodenal switch or one anastomosis gastric bypass might be better options for more effective weight loss. Revision options for a failed gastric bypass are much more complicated. These options can be largely divided into two groups. One method is adding further restriction by reducing pouch or GG anastomosis size, and the other method is intensifying malabsorptive components by making biliopancreatic limb longer. There is still no clear answer to which option is better, but a systematic review of the previous studies have suggested that the distalization of the gastric bypass can achieve sustained additional weight loss with acceptable complication rates. BPDDS seems to achieve excellent weight loss, but it is rarely performed, so the data is not sufficient yet. Endoscopic revision has been actively investigated in recent years, but failed to show a sustained weight loss effect in the long term and requires further investigation. Lastly, I would like to briefly introduce endoscopic bariatric procedures. Endoscopic bariatric procedures, as shown here, are emerging alternative for patients who are not eligible for surgery or who do not want to go for the surgery. They are known to achieve modest weight loss, but more research is needed to fully understand the long-term efficacy of these modalities. The endoscopic technology is evolving rapidly in recent years, and this represents an ongoing trend toward less invasive procedures. Among them, endoscopic sleeve gastroplasty is considered to be one of the best options. This novel endoscopic suturing technique can reduce the gastric luminal space as shown here, and the results resembles conventional sleeve gastrectomy. 5-year long-term results published recently, including more than 200 patients, show that the endoscopic sleeve gastroplasty achieved approximately 15% of weight loss and also demonstrated a sustained weight loss at least up to 5 years after procedure. So this appears to be quite promising. Endoscopic procedures are also evolving in the field of revision. In the patients with a failed gastric bypass, GJ anastomosis can be reduced with the endoscopic suturing technique along with the ESD or coagulation. Some of the recent series reported impressive results that the patient lost additional 10% or more of their body weight in 1 year, and we'll wait and see whether this efficacy can last even longer. So to summarize, in Korea, Class 3 obesity population is rapidly growing, particularly among the younger generation, which means patients who require bariatric and metabolic surgery would rapidly increase as well. Evidence from the long-term studies have suggested that the efficacy of metabolic surgery lasts over 10 years. Gastric bypass is marginally better than the sleeve gastrectomy in terms of weight loss at 5 or more years. And sleeve gastrectomy demonstrated a quite high incidence of weight regain and GERD in the longer term. So far, there is still no clear answer to the question which surgical option is better, and emerging surgical and endoscopic procedures also need further investigation in the longer term. Therefore, we always need to pay attention to the research updates to have answers to these questions in this ever-changing bariatric fields. Thank you for your kind attention.
Thank you very much for your informative summary for the update on the bariatric and metabolic surgery. Maybe there be tons of questions, but still we didn't get any questions from chat box. So waiting for the question. I would just a quick question about sleeve procedures. One of the benefits of the sleeve plus procedures is maybe there be a less dumping syndrome, you said. But sometimes we can observe dumping phenomenon after sleeve gastrectomy patient, even in the clinic and during the radiologic study. We can see the very fast transition of radiological material to the jejunum, even ileum as well. So do you really think about the benefit of the sleeve gastrectomy plus procedure? Is that
preventing dumping?
Preventing dumping.
I think the severity of the dumping symptom is much less, as much as I experienced. So after gastric bypass, the patients go back to their usual diet, and if they take any carbohydrate-rich diet, then they usually several of my patients already experienced the syncope symptoms and blackouts, but as far as I know, the sleeve DJB usually perform the DJB procedure, and they do not seem to experience that much severe dumping symptoms so far. So that's what I believe.
Yeah, better than.
Yes.
Okay. I can see a quick question from not from a participant, from Professor Moon-Yu. Could you please raise this question by yourself?
Yes. My question is, what kind of surgery do you perform for weight regain after sleeve gastrectomy in practice in your center, and why?
Actually, I do have several patients who requires a conversion or the revisional surgery after sleeve gastrectomy due to the weight loss failure, but patients refuse to undergo surgery. And actually, the decision to do the revisional surgery is very difficult because usually these patients have a problem with their eating behavior usually. So I usually recommend them additional weight loss medication first. And then still, if they do have some problems, then I will discuss, but I haven't tried any revisional surgery so far after sleeve gastrectomy, yes. And medication works very well, actually.
Okay, actually we are 5 minutes behind the schedule, but one more question. So, regarding the recidivism of weight regain, I just want to get your own opinion or personal experience about how you can solve this problem during the observation period, even less than 1 year. So what is your personal algorithm to solve this problem?
Actually, when
timing
I became to think that the earlier is better to intervene. So these days, when I see the patient lose not much weight in the early period, maybe at 3 or 6 months, and they do not catch up the amount of weight loss that I want, then I usually recommend the patients to have additional medications that will help. Because usually these patients have some, as I've already mentioned, they usually have a very problematic eating behavior. They usually have foods all the time, some high sugar diets. So the additional medication will help these stop these grazing symptoms. So usually these days I usually the medications early.
So please complete your study. One of your study. The other day, I know you plan to make some Korean standard weight profile after sleeve or Roux-en-Y gastric bypass.
Yes.
If you finish that project, you can more easily decide the timing or something like that.
Yes, additional intervention.
Thank you so much.
Thank you.
So let's move on to the second topic. The title is technical tips for sleeve gastrectomy. Will be delivered by Professor Sang-Hyun Kim from Soonchunhyang University. He is also actively participating the KS-MBS, and he's working as a director of Bariatric Surgery Center in Soonchunhyang Seoul University. Professor Kim, please.
Good morning, ladies and gentlemen. It is my great honor to have an opportunity to speak in KSL's 2021. Today's my talk is technical tips for laparoscopic sleeve gastrectomy. I have no COI disclosure. Picture taking is allowed except one slide. Presenting contents are as follows. Preparation before surgery, position and selection of trocars, liver retraction method, dissection and stapling of stomach, prevention of GERD, pain control, and other tips. Patients are placed in supine with legs separated, and they are firmly secured to the operating table with foot plate to allow for a stiff reverse Trendelenburg position. Intermittent compression devices should be employed to prevent venous thromboembolism. Operator stands on the right side of the patient, and scopist stands on between the legs. We sometimes change positions to maintain a comfortable posture. I usually use 4 ports. I put the first trocar into the point at 18 centimeters below xiphoid process and slightly left from the midline. If the point is close to umbilicus, I put the trocar into the umbilicus. I use 12 mm visible trocar with the hole at the tip enabled to insufflation with minimal penetration into the peritoneum. I put 15 mm trocar on right upper quadrant for inserting black cartridge when first stapling and for specimen removal. I use 12 mm trocar enabled to close fascia for third trocar on left lower quadrant and 5 mm trocar on left upper quadrant for assistant use. I use 15 cm long trocar when a patient's height is more than 180 cm or depth of abdominal wall is more than 6 cm. Liver retraction is crucial to identify G junction. When I first started sleeve gastrectomy, I used Nathan's retractor. As I got used to the operation, I switched to sling method as a first choice for liver retraction. This method can be used for most patients who have not so big and heavy liver. But sometimes this method is very difficult to retract liver sufficiently, especially for the patients who have a big and heavy liver or need hiatal hernia repair. In that situation, I use cupped T-stick with flex arm retractor because of the ease of use. Nathanson retractor is also very useful, but sometimes it is difficult to access into abdominal cavity because of the thick abdominal wall. It should prepare large size of Nathanson retractor for very big patients. Dissection of the stomach to proper extent is very important in creating a good gastric shape. I dissect the greater curvature from 4 cm proximal to the pylorus to the angle of his. For full mobilization of the fundus, I fully dissect posterior perigastric attachment and posterior gastric vessels until left crus is exposed. If the surgical view is excellent, I fully mobilize the fundus before stapling. But in most cases, I mobilize the fundus while stapling and resetting the stomach, because this makes it easier to pull the stomach and secure the field of vision. When the angle of his is not clearly identified, I remove the fat pad attached to the angle of his. But I don't dissect the angle of his excessively because I think doing this might increase the possibility of hiatal hernia. I always put 38 French bougie before stapling. I use 60 mm black cartridge when first stapling and then Use 60 mm purple cartridge for the rest. I usually insert first and second stapler into the 15 mm port at right side of the patient and the rest into the 12 mm port at left side of the patient for making good shape of sleeve. When stapling, I put the anvil side towards anterior wall of the stomach. This enables the staple line on the middle or posterior wall of the stomach. When stapling with anvil side towards the posterior wall of the stomach, the staple line lies on the anterior wall of the stomach. I think placing the staple line towards the posterior wall of the stomach will reduce the kinking of the stomach. To prevent stenosis and make the sleeve constantly thin, first tip is to fire staples 1 cm lateral to bougie. I always check the gap between the bougie and the staples using grasper tip before first and second firing. Second is not to pull the stomach too much. It makes the staple line zigzag and uneven. Third is to fire staples 1 cm lateral to easy junction. Fourth is not to double stapling, if possible. Double stapling creates dog ears on the edge of the stomach that may produce ischemia. Fifth is to adjust the sleeve size using the imbrication of the staple line. To prevent torsion of the stomach, it is important to place the stapler that anterior and posterior edges are at the same distance from the lesser curvature. But it is not so easy to make this. First tip is to keep the direction of anvil constant. Second is to affix the sleeve to omentum and retroperitoneum. If hiatal hernia is grade 3 on Hill classification as shown picture C with GERD symptoms, I usually perform hiatal hernia repair using 2-0 H-bond sutures. If hiatal hernia is grade 4 like picture D, I don't perform sleeve gastrectomy. Second tip is to pull the stomach downwards and fix it to the retroperitoneum in order to prevent the sleeved stomach from moving upwards even a little, but there is no scientific evidence. Staple line reinforcement is a still controversial step. 2014 panel reported that 43% of expert surgeons used buttressing material for staple line reinforcement, 29% oversewing, and 28% don't perform any staple line reinforcement. I usually imbrication suture technique from the upper edge to the mid-body of the stomach using non-observable barbed suture. And I always try to hide the staple line, especially the upper edge using this suture. But it should be better to suture with the bougie in place to avoid reducing the lumen size. From the mid-body of stomach, I usually suture the stomach with omentum and retroperitoneum, looking forward to preventing staple line bleeding and torsion of stomach. Some papers reported that fixation of the sleeve to these tissues decreased postoperative vomiting, staple line bleeding, or gastric axial rotation. I use one fascia closure trocar to easily close the fascia of the 15 and 12 mm ports. And I use endo-pouch for specimen removal. After I experienced surgical site infection, even though gentle removal without spillage of gastric contents. I use 3 methods for pain control. I injected bupivacaine at preperitoneal space of trocar site before trocar insertion. And I performed sono-guided subcostal transversus abdominis plane block and rectus sheath block after surgery. Third is IFSO. For abdominal nerve block, we mix 60 mg of bupivacaine with saline in a syringe and prepare it by connecting to IV line and spinal needle. After surgery, I inject 15 ml between internal oblique muscle and transverse abdominal muscle at right and left side abdominal wall and inject 15 ml between rectus muscle and posterior rectus sheath at each abdominal wall. In summary, complete mobilization of the fundus avoids leaving behind a large retained fundic pouch. Second, stapling away from 1 cm lateral to bougie avoids narrowing at the incisura and G junction. Lastly, equal opposition of the anterior and posterior aspects of the sleeve avoids torsion of the stomach. Thank you for kind attention.
Thank you. Thank you, Sang-Hyun, for your fantastic video. I got 2 questions from Asim. The first one, he said, do you practice pre-operative preparation for weight loss?
Actually, no. Yeah, actually, no, because actually between the first visit and operate day is not so far, just within one month. So, and the literature has some controversy pre-operative weight loss. So I just educate patients to do not eat at night. Just one educating. That's all.
Just for surgery.
Yeah.
Not for the successful weight loss.
Yeah, right.
Yes, they said the total amount of weight loss is not different between the groups. The preoperative preparation or not. Right?
Yeah.
Okay. Second question raised by Asim is about hiatal hernia. So he said suture repair of hiatal hernia, can you comment chances of recurrence after significant weight loss after sleeve gastrectomy?
Actually,
he may say the de novo type hiatal hernia.
Yeah,
something like
yeah. Actually, Dr. Asim has more experience than me, and I have maybe around 10 or 15 patients, because I do not routinely perform the hiatal hernia repair, but sometimes, as I shown the slides, grade 3, sometimes with the GERD symptoms, I sometimes the suture the hiatal hernia repair, and the guideline, the second edition of the ASMBS textbook, it mentions that the hiatal hernia repair is will be needed for the hiatal hernia for sleeve gastrectomy. So, and some literature has a benefit to hiatal hernia repair for some kinds of sleeve gastrectomy patients. So actually, but I don't have a lot of experience about the result of after hiatal hernia repair for sleeve gastrectomy. So I'm sorry to the exact the result.
Okay. Maybe that's for the answer to the question from Professor Jung-min Bak from Chungang University. He said, for patients with GERD symptom, hiatal hernia repair seems to be not enough to control GERD symptom. His question was the hiatal hernia repair really effective to control GERD patient who underwent the sleeve gastrectomy? So, yeah.
Yeah, I think so. I totally agree with Jung-min Bak. Yeah.
Yes, there's a bunch of questions about the hiatal hernia. So one more from Asim. He said, is that the sleeve with hiatal hernia repair more commonly result in the failure than success? Do you think so?
Yeah, actually, Dr. Asim has more experience, so
yeah.
I think
it could affect the weight loss profile, right?
Yeah.
Okay, last question from Professor Pa. Is there any specific reason that you use non-absorbable sutures? We can see that you use in your video, you use a non-absorbable sutures for staple line reinforcement. So is there any specific reason why you are using the reinforcement suture as a non-absorbable material?
Actually, in the textbook, the ASMBS book, it is okay to suture absorbable or non-absorbable suture. It is no difference between the suture, the material type. So actually, I learned from Dr. Kasama. Dr. Kasama always sutured the H-bond non-absorbable 2-0 suture. So and I follow his technique. And
okay, still we have tons of questions about a lot of things from your video, but we have to move on to the next topic. So thank you so much.
Yeah, thank you. Yeah.
Professor Yu, could you please take over this session?
Thank you. We move on to the third speakers. And I would like to introduce the third speaker. The speaker is Professor Kyung-Won from Kosin University in Korea. He will give a lecture on technical tips for laparoscopic Roux-en-Y gastric bypass. Please stream the professor's presentation.
Good morning, everyone. My name is Kyung-Won Seo, from Kosin University in Busan, Korea. The topic given in this section is technical tips for laparoscopic Roux-en-Y gastric bypass. I have no disclosure. I allow picture taking during my presentation. Please feel free taking a picture and discussing heartily. Today, I'm going to talk about a general overview of bariatric surgery, one of the ways to treat obesity. In particular, I will focus on the surgical techniques of laparoscopic Roux-en-Y gastric bypass, which are currently most commonly performed in the world. Obesity has become one of the most significant public health problems in the world. This is a common challenge in developed and developing regions. Obesity is associated with markedly reduced life expectancy, so it is a leading cause of preventable death. Obesity is also associated with hypertension, heart disease, type 2 diabetes, obstructive sleep apnea, etc. Moreover, healthcare costs about obesity are high and climbing now. Its economic burden is becoming a global challenge of public health for individual countries. In the treatment of obesity, there are several ways of lifestyle change, including eating plan, exercise, and medication. But because of the yo-yo phenomenon after medical treatment, bariatric surgery is now considered the first management options for failure of medical treatment and the most effective method for sustained long-term weight loss. Conceptually speaking, bariatric procedures are thought to induce weight loss by causing caloric restriction and/or malabsorption. Recently, new mechanism of gastrointestinal tract as a key regulator of energy and glucose homeostasis was introduced. Anyway, nowadays, sleeve gastrectomy and gastric bypass is most commonly performed by a bariatric procedure in the world. In the Western countries, indications of bariatric surgery follows this standard established by NIH in 1991. BMI over 40 or a BMI of 35 or more and one medical comorbidity such as type 2 diabetes and hypertension, etc. In Korea, newly introduced reimbursement criteria of national health insurance started from 1st January 2019. For Asian people, including Korean, the BMI is lowered by 5. The reason is that Asians are more susceptible to comorbidities caused by weight gain than Caucasians. First issue is current trend of bariatric surgery. According to IFSO registry report 2013, Roux-en-Y gastric bypass is the most commonly performed procedure in the world. However, the case number of sleeve gastrectomy increased 5 times in 2011 compared to 2008. In Asia Pacific area, sleeve gastrectomy has already become the most common surgical method in 2011. In IFSO Registry Report 2018, sleeve gastrectomy accounts for 45% of all types of surgery. The total number of sleeve gastrectomy is 10,000 more compared to Roux-en-Y gastric bypass. In the same report, sleeve gastrectomy is the main procedure on the most continent. In Western Europe and North and South America, Roux-en-Y gastric bypass is a bit more performed. IFSO registry also showed similar outcomes about comorbidities enhancement between two procedures. So, bypass and sleeve gastrectomy is the main bariatric procedure in the world. Next, I will explain laparoscopic Roux-en-Y gastric bypass with a focus on surgical technique. During surgery, intubating patients with obesity can be difficult, so every precaution should be taken. A lamp that elevates the patient's torso can allow somebody pad to fall away from the head and neck area. For the convenience of patient transport from bed to bed, the equipment which is easily moving will be required. Obese patients have a large and heavy liver due to fatty liver, making it difficult to secure a sufficient working space. If you perform liver retraction using the Nathan's retractor and in the liver Trendelenburg position, the stomach is pulled down by the weight of momentum, so you can easily do bariatric surgery. At this time, foot pads are required to prevent the patient from sleeping. The component of bypass is gastric pouch formation, gastrojejunectomy, jejunectomy, and defect closure. Trocar position is similar to sleeve gastrectomy. Pouch formation starts from making space at the level of hiatus. Next step is horizontal stapling with 45 purple and followed by 2 or 3 vertical stapling oriented to the his angle. The gold finger is passed from the right side to the left side to spread the stomach and allow the linear stapler to be inserted. During creation of a gastric pouch, posterior visualization at the level of the hiatus is not easy because of the variable level of adhesion to the pancreas, so it is better to enter the lesser sac via the opening of the gastric colic ligament and to detach the posterior gastric adhesion. I will show this video in the next slide. Many surgeons bluntly dissect behind the stomach to making posterior visualization. If we forcefully go through this process, pancreas trauma or splenic artery injury may occur. Entering the lesser sac is easy and we can confirm posterior adhesion between stomach and pancreas. After this preparation, we can insert post-stapling very easily. Next procedure is bypass and anastomosis. I will compare standard Roux-en-Y gastric bypass documented by several textbooks and U-loop style bypass presented by Dr. Eric Dawson in UCLA. According to textbook, first step is jejunostomy performed below the ligament of trach. During bypass, the length of the small intestine that we are contracting is long, so if we get confused about the direction of the small intestine, we may experience a catastrophe that creates a Roux-en-Y misconstruction as shown in this picture. This modified procedure is not special. In this procedure, to-do step in order is important. After creating gastric pouch, we have to measure biliopancreatic limb about 70 to 100 cm from triach ligament. After that, gastrojejunectomy is created by linear stapler. Next is cutting jejunum, followed measuring Roux limb about 100 cm. Finally, jejunectomy is the last step. This modified method can prevent confusing bowel alignment and misconnection. I will show my procedure of laparoscopic Roux-en-Y gastric bypass. During Roux-en-Y gastric bypass, one thing to do firstly is creating window between stomach and left crus using electrocautery or harmonic scalpel. Making small gastric pouch is explained in the previous slide. We are making horizontal hole at the lateral gastric spaces. First, purple stapler is inserted horizontally. We make additional stitch to retract gastric pouch laterally. The gastroplanic window previously created above the left crus should be identified from the lateral gastric approach. After this step, complete division of the stomach is confirmed. And we make a small hole at the small gastric pouch for the gastrojejunectomy. Measuring biliopancreatic limb about 100 cm is the next step. Gastrojejunectomy with isoperistatic passion is performed by purple 30 mm. Division of jejunum is performed by 1045 or 60 mm. Measuring Roux rim 100 cm is the next step. Creating jejunostomy is performed by 10-45 mm. Entry hole closure is done by suturing or additional stapling. I prefer suturing by barbed suture. Entry hole closure of the gastrojejunostomy is done same as the jejunostomy. Closure of a mesenteric defect is done by non-observable suture. Closure of Peterson defect is done as shown in the previous step. This step is important to prevent internal hernia occurrence. To prevent port site hernia, port site closure using device is mandatory over 10 mm port. For 5 mm port, close is not necessary. In summary, metabolic and bariatric surgery is the effective treatment option to treat obesity itself and its comorbidities. Sleeve gastrectomy and Roux-en-Y gastric bypass is the most commonly performed procedure in the world. Learning and implementing accurate technique step by step prevents complications and can get satisfactory results. Thank you for your attention.
We thank you very much for your informative presentation. From now, we would like to start Q&A time. There is a question from Asim Shabbir. Would you ever believe momentum in your bypass surgery, please? Bypass?
Bypass?
I don't understand the bypass.
I don't understand the so.
Okay. A split momentum.
Split momentum. Okay. I am a beginner bariatric surgeon, but I experienced the cases to the split momentum because of the patient is a very severe obesity. I remember the patient's BMI is 55. I agree, Dr. Asim's opinion. That we have to bipartition momentum because of the gastrojejunostomy tension is very high. If we did not momentum bipartition.
Okay, next question is from Professor Yeon. Yeon point the size of GJ anastomosis. What do you think about the impact of GJ anastomosis size on weight loss?
Oh, thank you for a very good question, and I agree. The gastrojejunostomy size is very important to the impact on the weight loss. But I try the 20 millimeter stapling using the 30 millimeter stapler. But in this video, is made at 1 year ago. So the assistance support is not sufficient. I did not the exact 20 millimeter anastomosis, but recently I tried the 20 millimeter assistant stapling for the adjusting the GJ anastomosis size.
Okay, although there is a question from Park Jung-min, but that question is related to stoma size. So another question is there any reason to close the GJ anastomosis after JJ anastomosis? Maybe bacterial inoculation is my concern.
Sorry, bacterial.
Why do you close the GJ common channel after JJ stomy?
It is just my order of my procedure. I don't any specific reason. I don't have any specific reason. So your opinion is a bacterial transfer from JJ to GJ, right?
No. From via GJ open common channel, the bacteria spreading to peritoneal cavity is possible. So I think after closure the common channel of GJ, then the next procedure is better.
Okay. Okay. I am focusing on the order of a procedure. So I did not recognize your opinion. I will be cautious of the bacterial transfer into the abdominal cavity. I just do this procedure after stapling, and anterior closure is the last step. So because I am focusing on the direction of the bowel alignment, I don't have the specific reason.
Okay, there is a lot of question, but because of time limit, we move to next topic. The next topic speaker is Professor Asim Shabbir from National University Hospital, Singapore. He is also director of Center for Obesity Management and Surgery, National University Hospital, Singapore. And he will give a lecture on postoperative complication management after bariatric and metabolic surgery. Please stream the Dr. Asim's presentation.
A very good morning. Thank you to the organizers for the opportunity to present on the postoperative complications following bariatric surgery. I'm Asim Shabbir from the National University Hospital in Singapore. I have no conflict of interest with regards to this presentation. Please, you may feel free to take pictures and record if you wish to. This is my case mix. Largely my experience is based on bypasses and sleeve gastrectomy. So what I would cover are some specific complications and overall evaluation and management of complications in bariatric surgery today. So basically, one of the first things in managing patients with bariatric surgery is actually to know the kind of procedure, what anatomy it results in. In my institution, the most commonly performed procedures are sleeve gastrectomy, Roux-en-Y gastric bypass, one anastomosis bypass. The remaining are others that we hardly see occur in our institutions. Symptoms are generally those common of upper GI presentation, including bleeding, pain, nausea, and vomiting. Signs are of unstable vital signs, most importantly being tachycardia, fever. The basic management, if you want to do an assessment on patients who are morbidly obese, it is difficult to get anything out of the abdomen because of the thickness of fat. You may not be able to elicit tenderness, and this is one of the drawbacks of clinical examination. Imaging modalities like CT scans can be frequently used to find out sources of bleeding and leaks in these patients. The basics of management in these patients include that the emergency team lets the surgical team know of the admission as soon as possible, because time is limited and time saves the life of these patients. An NG tube may or may not be necessary, and if it's an early patient after early surgery, NG tubes are not mandatory. Try and avoid the use of anticoagulants, steroids, NSAID, because they cause more bleeding, they result in renal failures, so be cautious with their use. Use PPI frequently as they help heal the patient, and if they are alcohol dependent, please give them thiamine. These are from the ASMBS guidelines. Now let's go on to the first important complication, which is bleeding. Bleeding can be intraluminal or extraluminal. If it's intraluminal, then an endoscopy is what is the best modality. If endoscopy fails or you cannot detect it, then other modalities like CT scan can be used and embolization can be done. However, in the case of an uncontrolled hemorrhage, surgery is indicated. It occurs in about 1% of patients undergoing sleeve gastrectomy and less than 0.5% in those going through Roux-en-Y bypass. This is one of our patients with intraluminal bleed from an anastomosis. You just need to open one portion of the anastomosis, suck out all the clots, and overrun the entire anastomosis. Redoing the entire anastomosis is not necessary. On the right hand side here is the patient with a post-sleeve gastrectomy. You can see that despite the use of a buttress material, there was a bleed. This patient was on anticoagulant that was stopped a day prior, and maybe using things like glues may decrease the incidence of bleeding. Here I put a simple suture and it stopped. So you can see the bleeder in the bypass now there, which is very visible, and what we do is just overrun the entire anastomosis, and that helps stop the bleeding. So now we talk about leaks. Leaks are important because failure to diagnose leak can result in high mortality, as high as 15%. It is fortunately rare both after sleeve gastrectomy and bypass, however, a very difficult morbidity to manage. What is important is that you are always aware of the fact that a leak can happen, otherwise it would be missed. The most subtle signs are tachycardia, fever, abdominal pain in these patients. Never rely on tenderness. Principles of management are broad spectrum antibiotic coverage to find the leak and repair the leak, irrigation and control of contamination, whether you do that through radiological drainage, through endoscopic drainage, or surgical drainage, and then make sure that the patient has a feeding mechanism, whether that's parenteral feeding or oral feeding in place. You can use stuff like stem. This is a patient who underwent a bypass, and you can see that we're trying to find out where the issue is. There are lots of clot, probably bled from the side of leak. This is about post-op day 5, using an endoscopy just to blow air, and you can see that the bubbles start arising in this region. Once the bubbles arise after blowing in the endoscopy, as you can see in the endoscopic picture, you know where the area of leak is, and all you need to do is just put a stitch across. Since it's a low pressure system, it will heal well. On the other hand, this is a patient that we received from another hospital who had a leak, and we looked at the gastrojejunostomy of this patient, the jejunal jejunostomy, and ultimately found that there was an inadvertent small bowel injury in this patient that had resulted in this leak and peritonitis. As you can see here, the margins are freshened and then the leak area is closed, and it was good to detect this early. Now, how do you manage sleeve leaks, because these are problematic? Endoscopic versus surgical management. Any patient who is hemodynamically unstable actually requires a surgical, or has peritonitis, requires a surgical intervention, whereas the others can probably and is recommended that they manage through endoscopic routes. If surgery, you do a washout, debride, close. Defects that are 3 days and less are best closed, and they will be successful. Beyond 3 days, the margins become unhealthy and closure does not succeed. Laparoscopic closure is the preferred modality because of the success, about 80%, versus doing it as an open procedure where success rates are only about 43%. Now, as I said, the other indication for patients who need to go through sleeve through surgery are those who have multiple pocketed or lobulated subphrenic abscesses where non-endoscopic, non-surgical measures will not work. Alternatives to primary closure of the defect include things like excision of fistula, fistulojejunostomy, conversion to Roux-en-Y bypass, and even jejunal patch. So if ultimately endoscopic measures fail, surgery can be introduced, and this is around 6 months, because beyond 6 months the success of endoscopy treatment is low. As you can see in this paper, it drops from 76% success rate at 1 month to about 48% at 6 months. This is one patient that I had the honor to manage, and this is thank you to the primary surgeon who gave me the video. You can see the area of injury here in this patient. This is the area where the injury would happen, and exactly on POD4, this is a harmonics related injury. You can see the leak area here. And the surgeon attempted to do a primary closure on post-op day 4, and it wasn't successful. The patient was brought to our institution. We converted the patient to a Roux-en-Y bypass. You can see here the patient being converted to a Roux-en-Y bypass, and the patient did well, was discharged on POD 10. Is there increased morbidity of operating in such patients? The morbidity is about 5% reported in literature, and it saves a lot of cost. And the reason I'm saying this is that endoscopic therapy, the difference between endoscopy therapy and surgical therapy is the difference in the cost for endoscopy and surgery. However, the bulk of the cost is for caring for these patients in ICUs in the ward for long periods of time, which may be as long as 6 months in these cases, and that may not be a great option for these patients because financially it will be draining. Now, this is an algorithm for management of patients endoscopically, and it is dependent upon whether you can drain the abscess through percutaneous measures. If not, then through endoscopic internal drainage. If you can, then depending upon the size, they would recommend using things like OTC clip and using endoscopic suturing and tissue glues. I think the OTC clip have been very widely used. However, be cautious that a recent report reports a failure of up to 47%. So again, it is best that if you put an OTC clip, a stent is placed, and the abscess that is outside is drained. Use of stents is, I would share in a bit. As far as the other drainage of transluminal drainage through the fistula using a double PICC stent has shown very promising outcomes in these patients. That's one. Endoscopic therapy, the overall success rate is about 73%. However, with time it decreases. What predicts for a good endoscopic closure is early detection, early intervention as early as 21 days, and smaller leak size less than 1 centimeter would determine the success of that. This is stent, and you can see that stents are good because they cause occlusion. However, the problem with stents is that there is parastent leak. They do erode, they migrate. Even the mega stents have their own problems, difficult to remove, and may not be 100% in what you could achieve for that period of time. This is a patient post-bypass who has a leak. You can see the jejunal limb here, the blind limb here, and that's the leak site, and you can see on the contrast the leak happening. The patient underwent a safe stenting. A stent is deployed. After 4 weeks, the stent was removed, but you can see that the stent is embedded and it is difficult to remove. So another stent was deployed to remove the stent, left it in for 1 week, and you can see ultimately the area had healed. However, you cannot leave these stents for more than 6 weeks as they cause great disruption and may actually perforate themselves. There are newer concepts like lumen opposing stents, which can actually be used to create a less less hostile environment, and you can drain them. Fibrin glue or sealants do not really work. In chronic leaks, a septoplasty may help converge the cavity into one big cavity. I've talked about Ovasco clip. The endo sponge is not widely available yet. It is tedious, normally takes about 6 changes at an interval of about 2.5 days each, requiring general anesthesia, which makes it not a favorable choice at the time. Let's talk about reflux. Post-sleeve gastrectomy patients may develop reflux. Here is a patient of mine that's been converted for reflux to a Roux-en-Y gastric bypass. I have come across the use of this Thorax, which is basically the Lynx device for my patients. I've done about 10 cases of these. However, I must caution that the technology is not ready for prime time for patients with sleeve gastrectomy, and this is due to the fact that there is upstream dilatation of the esophagus, which results in poor clearance, and these patients may continue to develop symptoms until further data is available. I would caution one against the use of these in patients with post-reflux disease. That's the Lynx going in, and that's the bypass being done. So there are other complications over time that happen in patients who have basically the disease process, who have gone through, and we will discuss these. These are just timelines for these processes, and incisional hernias, marginal ulcers. These are long-term complications that we are now going to discuss. Marginal ulcer, this is one of my patients who's basically gone through a Roux-en-Y bypass, and you can see the patient basically having a marginal ulcer there. 3 months of treatment with PPI, sucralfate. The patient was a smoker. It happens. If it doesn't, or there is cicatril, one may have to go in to revise the marginal ulcer, do a vagotomy, refashion the pouch to a smaller pouch. Surgical intervention should be limited and to patients who are rather more chronic. Internal hernias are an important complication, though fortunately very rare, about less than 6%. It depends upon how you do your bypasses. I do my bypasses anti-colic, so the mesocolic defect does not exist, but the mesenteric defect exists, and the Peterson's defect exists. Most of the time with the rapid weight loss, the Peterson defects may be quite a notorious cause for internal hernias. Here you can see a swirled sign here, which is basically a sign of internal hernia. This is one of my patients, and you can see the bowel has gone through. I have reduced the bowel to the effect that I can see the duodenojejunal flexure, and then I repair the defect using a non-absorbable ethibond. I practice closure of all my defects intraoperatively at primary surgery. There are people who do not believe in, although the analysis suggests that all defects, whether they are Peterson, mesenteric, or mesocolic defects, need to be closed. Once this defect was closed, the patient was well. When you suspect an internal hernia, please make arrangements to do it or repair it as soon as possible because of risk of bowel ischemia in these patients. So this was how it was repaired, and the patient is well thereafter. Now let's talk about a little bit about nutritional deficiencies. Protein deficiency, as I would show you, is not only common in bypass procedures, but to a mild degree happens even in patients with sleeve in patients here. Intake of 1 to 1.5 grams of protein per day for ideal body weight is what it is, and it generally happens in the first 6 months of surgery because of various losses. Here you can see that even after sleeve gastrectomy, 16% of patients actually had mild protein malnutrition. So be sure that you take care of these nutritions actively, prescribe protein to your patients actively. Iron deficiency is common, especially in women of childbearing age, and the incidence has been reported as to be anywhere between 12 to 47%. Using transferrin is a better measure as compared to serum iron and ferritin because of increased inflammation. In an inflammation, hepcidin, which is an acute phase liver protein, blocks iron absorption in intestine, so they are deficient. Vitamin C enhances it. I have come to the extent that before discharging my patients, I would give them IV Ferinject to top up their iron levels and then supplement them oral. Otherwise, you see a lot of deficiencies happening in this patient. The other common deficiency we see is vitamin B12 deficiency. Happens in about 1/3 of those patients who undergo Roux-en-Y gastric bypass, and the prevalence is overall 18%. Simple simple multivitamin supplementations is not enough. I give my patients anywhere between 500 to 1,000 micrograms of vitamin B12 every day. If they are not stable, I would give them vitamin B12 injection. Now, this is kind of a quiz question for everybody. Take a pause, look at this patient, and see what is the deficiency that you can see here. I was puzzled. We did a panel. This patient basically had a sleeve gastrectomy somewhere, came in, and then somebody did a Roux-en-Y bypass on her. She wasn't compliant to her vitamins intake, and she wasn't compliant to her protein intake, and this what it resulted in. So now, after doing all this, we did a panel. We couldn't get the answer. But the long and short of answer is that this patient became zinc deficient. And when we did the zinc panel, we found it out that it was extremely low. By then, the patient had gone into extremis. The patient was hypoalbuminemic, needed to be intubated because of refeeding syndrome, took 3 weeks to be extubated. And then ultimately, when the zinc was replaced, all these lesions patients. With that, I would like to end my talk. I would like to thank all these great people who have contributed to the management of our patients, and it is because of all these great people that we have been able to manage these complications and look forward to managing many more and supporting the bariatric field in Singapore. With that, I come to the end of my presentation. I would like to thank you for taking your time to be with us and listening to this talk. Appreciate it. Goodbye. Thank you.
Thank you for your wonderful lecture. And from now, we would like to start Q&A time. There is the question from Jeon Park from Korea. The first is, from your experience, what do you think is the best therapeutic option in patient with a high leak after sleeve gastrectomy, which is noticed in 1 or 2 weeks after surgery?
So it really depends upon the time of diagnosis. So this is still an early leak. If you diagnose it very early, most probably a staple line failure, and there is no distal stenosis. You can still manage it endoscopically with drainage. However, as I said in my presentation, my opinion is slightly different. I take if it is stable, I take a more aggressive approach. I convert the patient into Roux-en-Y gastric bypass. This is a lower pressure system. The chances of the leak to heal is well. If you look at all the endoscopic managements, they call endoscopic failure at about 3 to 6 months of endoscopic intervention. Unfortunately, my patients would not be able to stay from their schedules, if they can't stay away from their schedules and it costs a lot of money to them, then I think for me it makes sense to do surgical intervention. But endoscopic is equally well with drainage, so that's fine.
Okay, second question. In patients who require long-term use of antiplatelet and developed repeated marginal ulcer after, which option would you recommend?
So first of all, we need to understand why marginal ulcers develop. Right. So the early marginal ulcers after a Roux-en-Y gastric bypass. Okay. So one of the most common reasons is if patients are things on like aspirin, there is more acid production. In those cases, you can convert the aspirin to something like clopidogrel, Plavix, and all these substances, and generally they will tend to heal. If there is Helicobacter pylori, treat the Helicobacter pylori. If there is smokers, ask them to stop smoking. If all fails and the ulcer is chronic, you may go in, do an ulcerectomy, redo the anastomosis, and I personally do a truncal vagotomy at that stage. And if the pouch is very large, minimize the pouch. That would be my approach.
Okay, because of time limit, we would like to wrap up this session. We thank you very much for your participation. The next session, next session, keynote lecture 1 will start in via channel 1. Thank you very much.